So my briefest talk is 10 minutes about referral for heart transplantation. And Steve Clark asked me to talk based on a paper that was published in Heart in 2011. So for those of you who are interested, let's see how it works. So the paper in question, the first one up there, which came in Heart in 2011. It was a working group set up between between NHS Blood and Transplant and the British Cardiac Society, giving people sort of guidelines as to whom to refer for heart transplantation. The second paper up there is an ISHLT paper giving guidelines for assessment for heart transplantation. That was published in 2006, and I know the ISHLT is updating their sort of consensus conference data this year, so there should be something coming out in the next 6 months or so. So the common indications for heart transplantation haven't really changed. So the first one is patients with ongoing symptoms of heart failure at rest or minimal exertion on optimal medical therapy. Functional capacity measured by peak VO2 is an integral part of this assessment, and it's generally for the last sort of 20 years been accepted that a peak VO2 below 14 is the sort of time when you should start thinking about it. However, in the beta blocker era, many people think they should be cut down to about 12, because beta blockers improve survival, they do not improve exercise capacity. Second indication is those patients with recurrent admissions to hospital with heart failure, despite optimal medical therapy, even if they are reasonably well between episodes. But they should be on optimal medical therapy and they should be taking that pill. Third indication is always down in the books. This is refractory ischemia not amenable to revascularization, associated with poor LV function. I have to say this is becoming an increasingly rare reason for us to accept patients in this era. As you have falling number of donor hearts, it becomes hard to justify people for this indication alone, because many of these patients actually benefit in terms of sort of quality of life, but their need is less urgent, if you like. And the fourth indication, I think, is becoming more frequent, at least we seem to be seeing more of it. Patients with recurrent symptomatic ventricular arrhythmias with severe impairment of LV function. So the electrophysiologists have burnt everything they can, and the patient still has VT. And that happens, I think, more and more now. When you look at a patient, you're looking at two things. One is, what are the relative risks and benefits for that patient? So is he or she more likely to survive longer or shorter with the transplants compared to optimal medical therapy? But also the benefit for that patient relative to the other patients, the bigger population out there. So the relative benefit for that patient, how much benefit are they going to get? What I mean by that is, suppose you have someone who's going to die in the next week, but their 1 year survival is, say, for 40%. You might say for that patient, that is worthwhile. However, if median survival at 1 year is 80 or 90%, that may not be the best use of a donor organ. All centers list patients in MDT. It is meant to be as transparent as possible, and generally is, but it is not an exact science, and therefore I think it's important that all of us admit that there are patients at the sort of at the borderlines where one center might say yes, another might say no. So we usually offer them another opinion in another center if the patient wants it. So, for instance, I at Cambridge would often send patients to Harefield, and similarly, Nick Banner at Harefield often writes to me about patients from there. All patients before being assessed should be on optimal medical therapy, and that should include all these drugs. And if they're not on those drugs, there should be a good reason why they aren't on them. We should also discontinue drugs that are no longer helping, and you'd be surprised how many patients come for transplant assessment taking drugs that they shouldn't be on, including calcium antagonists, non-steroidal anti-inflammatory drugs, all sorts of things. The need for down titration of drugs, what I mean is, if you have to start cutting down on ACE inhibitors or beta blockers because of hypotension and worsening renal function, it is a sign of worse outcomes, and that is in itself is a reason to consider the next step. You're referring for a heart transplant. all patients who are candidates for cardiac resynchronization or biventricular pacing should have biventricular pacing done before referring for a heart transplant, because some patients are going to improve a lot. Similarly, those who might benefit from an ICD should have an ICD. Now, patients with end-stage heart failure who are, on inotropes and so on, don't waste your time with ICDs, they don't have any benefit. So, sitting at the other end, not in the transplant center, but in the referring hospital, what are you looking for? So, patients with 2 or more admissions for treatment of decompensated heart failure within the last year, that in itself should prompt people to actually send patients out. This presupposes that the treatment has been optimal, of course, and that the patients are taking their medication at home. Patients who have persistent evidence of heart failure, they still have breathlessness in spite of optimal medical therapy, their peripheral edema doesn't go away. When you're following up the echo, what you're looking for? You're looking for evidence of worsening right ventricular function. Most of these patients have systolic LV disease anyway. That isn't going to get worse, or may not apparently get worse. The RV starts getting worse, the pulmonary pressure starts to rise. That should prompt a referral. Deteriorating end organ function, mainly renal function. So patients who cannot tolerate diuretics because of worsening renal function should be sent out. And really you want referral before the estimated GFR falls below 40 minutes per minute per 1.73 meter squared, the body surface area. If you wait for patient with an end-stage renal failure, that is too late. Again, significant episode of ventricular arrhythmia is another reason to think of it. Rising BNP, for those who believe in BNPs, rising BNPs despite optimal medical therapy will actually pulls out a patient population that is going to do badly. And these other cytokine attributed abnormalities, anemia, weight loss, liver dysfunction, hyponatremia, all these should prompt referral. And finally, if you're interested in heart failure survival scores, something like the Seattle Heart Failure Model score, indicating a 1-year mortality above 20%. So that's an example of the Seattle Heart Failure Model, which you can download off the web. It's free. And it just puts in things that most patients you have for. You don't need to do any sort of fancy test. Just things like age, gender, NYHA score, weight, ejection fraction, blood pressure, drug therapy, and so on. And you put in all that and give you a calculated score, so you can see there 1 year survival, 2 year survival, 5 year survival. Anyone with a 1 year survival below 80%, one should think about referral. What are the indications for urgent referral? Well, anyone who's on inotropes and can't be weaned, obviously. Anyone who requires an intravenous. Patients who have no scope for revascularization with ongoing ischemia. As I said, ischemia per se becomes a rare indication. And again, intractable ventricular arrhythmias. All these in the absence of other contraindications. So what are the relative and absolute contraindications? So number one, renal dysfunction. Becoming an increasing problem because our management of heart failure is improved. But as we manage them for longer, yes, you have patients surviving with worse renal function. Generally, a estimated GFR below 40 or a creatinine clearance below 50 is thought to be a relative contraindication. It partly depends on how long it's been impaired for, whether it's thought to be heart failure and so on. Pulmonary hypertension. Again, more and more patients come with high pulmonary artery pressures now. And although there's no absolute level, these are sort of levels that are quoted in the paper as a realistic guide. So pulmonary vascular resistance about 5 units, transpulmonary pressure gradient about 15, and pulmonary artery systolic pressure above 60. On optimal therapy, which may include vasodilator therapy, inotropes, and so on. Anyone with a recent pulmonary embolism, we generally advise waiting for at least 6 weeks. So this is an example of someone who has high pulmonary artery pressure. So if you look at this is all the same patient over the course of 9 months, just with optimizing medical therapy. So on the first catheter, you've got very high right atrial pressure, pulmonary artery pressure is very high, cardiac output is very low. The transpulmonary pressure gradient is the mean PA pressure of 53 minus the wedge pressure, and the pulmonary vascular resistance is the transpulmonary gradient divided by the cardiac output. So you can see the pulmonary vascular resistance starts off at 8.5. Few months later is down to 6, but still high. 5 months after that, you've got increasing cardiac output, falling pulmonary artery pressures. It tells you that medical therapy does actually work. And at that stage, the patient is now a fit candidate for a heart transplant, but actually is feeling quite well and doesn't need to go on the list. And I'm still following him up, actually. Diabetes mellitus per se is not a reason not to put someone on the list for a heart transplant, but two things: you need to establish quick control, and you need the absence of non-cardiac endorgan damage. Obesity becoming an increasing sort of problem now. The ISHLT guidelines and the UK paper says ideally BMI below 30. We're not always that strict, but certainly not many patients with BMI above 32, 33 are going to go on the list. Symptomatic cerebral or peripheral vascular disease is a marker of poor long-term outcome, and therefore probably the patient shouldn't have a heart transplant. Active infections, obviously you want to treat the active infections before patients go on the list. Chronic viral infections are a moving sort of feast now. Things are changing. People argue now that even HIV should not be a reason not to, because long-term survival in patients with adequately treated HIV isn't bad. You have now many patients who've had Hep B in the past but on anti-Hep B therapy. The viral titers are now 0, and people think these are now reasonable candidates. However, I must say we don't have long-term survival data on this population yet. Active malignancy other than non-melanoma skin cancer is generally thought to be a no-no. However, patients who've had a cancer many years in the past should be okay, and actually we're seeing more and more patients now with what's called chemotherapy-associated cardiomyopathies, both from acute leukemias and increasingly now from things like breast cancer, because many of the newer anti-breast cancer drugs in the long term are going to increase the number of patients with heart failure. So I think this is a group we can see more and more. Substance misuse is generally thought to be a reason not to put patients on the list. That may include excessive alcohol and active smoking. You've got to be a bit pragmatic about this. If someone who's a smoker has an infarct and is in shock, you're not going to say they'll come back in 6 months' time. Yeah. History of patients who are who don't attend, who don't take their pills, and of course finding patients who are capable of giving informed consent. They should understand what they're signing up for. So just to conclude, I would say it's better to refer too early rather than too late. And if in any doubt whether someone is a reasonable transplant candidate, the best thing is to ring your local transplant center, talk to someone there, a physician or a surgeon, and they can